The following is a paid commercial program. Unless otherwise identified, the guests on the program are employees of the advertiser. Opinions expressed are those of the advertiser and do not necessarily reflect the views and policies of Global News Radio 640 Toronto.
Good morning and welcome to the PinPoint Health Show on Global News Radio. I'm Danny Longo, filling in for John Scholes, and I'm with Dr. Lou. Doc, how's it going?
Good, you? Thanks, Danny, for being here.
Thank you.
I'm having a little difficulty on the headphones hearing you, but I can hear you obviously speak, so we'll get this sorted out.
Perfect.
Danny, thanks for being here with us today. Typically, we start the show off speaking about things that have happened through the week, some interesting cases. And then I was mentioning off air, the natural curiosity that you might have on things would be interesting without John being here and going through some of those things. But I mean, after last week, we had Dr. Henry Candelera in who was talking about low back issues.
Yeah, it was a great show.
And so there was sort of an influx this week of people with low back pain, which there's always an influx of people with low back pain just because of how very common it is. 80% of the population at some point will experience some type of spine-related back pain and low back pain being more common than, upper back pain and neck pain. Neck pain would be second most common, and the thoracic area, the upper back, the least most common because of the inherent stability with the rib cage. Whereas the other two segments, it's just really soft tissues supporting its structure and holding it upright. The low back being more common because of gravity. You just got more weight down there, so it sort of makes sense for people in that regard. And a lot of what we went through last week was really focusing on figuring out. Back pain, I always tell people, is like telling someone, like, if you came to see me and you had a fever and I just told you had a fever, you probably wouldn't be too happy with me because it's like, well, I knew that coming in.
But my back hurts.
Yeah, exactly. Yeah. So most people, there's a diagnosis of mechanical back pain and people are like, oh, geez, like I knew I had back pain before I came here and now I'm being told I have back pain. It's confirmed. So it's funny that sort of the diagnosis can also be sort of the symptom that people experience. But I guess the important part to consider is what you put in front of that word back pain. And the mechanical aspect of back pain being the most common, 95% of spine-related pain is called mechanical back pain. And that mechanical is really the diagnosis. That's the important part. And what that essentially means is it's related to the mechanics and the movement of things going on.
So like just day-to-day wear and tear kind of stuff?
Yeah, the movement aspect, everything. The wear and tear aspect is actually the part that doesn't matter that much because everything we have, there's a wear and tear component, right?
Yeah,
so you've probably heard of things like degenerative disc disease, and people will walk around saying, I have an x-ray and it says I have degenerative disc disease, and that's why I have low back pain. Most often, not really. That's not usually the reason for spine-related pain. That's what we would call an incidental finding. It's sort of like gray hair of the skeleton. So as you age, you're going to have any joint in your body is going to degenerate. The question becomes at any given static point in time when we're looking at it, is the degeneration more than we would expect at that age, right? So there are instances where things could degenerate to a point where it's more severe than we would expect. A good example of that is things like autoimmune diseases. So say somebody has like rheumatoid arthritis, and that rheumatoid arthritis is attacking a joint and it's causing it to degenerate at a severe level in someone who's 30 or 40 years old. That's a problem.
Yeah.
If we see severe degeneration, I've seen people that have very severely degenerated joints, but they're 90 or 92 or 93. It sort of makes sense because temporally you start to look at it, and it's, of course, throughout your age and the wear and tear, the gravity, all of the things of being human that have weared out on you, that is going to lead to that. Now, that doesn't mean severe. Anytime you get to severe, that will likely cause the pain, would probably be the cause of pain. But again, in order to get to severe, you would typically expect that in much older individuals. Most people that develop spine-related pain can develop it very early on. And so we see a lot of people that might be 40, 45, whatever age group saying, I've been told I have degenerative disc disease. Mild to moderate, even in the moderate, maybe towards severe, it doesn't really matter that much. And that's the thing. Now, there are instances where that degenerative aspect, maybe it's degenerating in such a way that it might be putting pressure on a nerve or something like that. That might be significant, but that would create probably very specific symptoms. So a good example of that degenerative aspect that happens will lead to what's called osteophyte formations, which are just bony extensions, right?
Okay.
And those bony extensions, if that pushes on a nerve, that will create very specific nerve-related pain. So someone who comes in and says, listen, and this is what stenosis is, spinal stenosis, which we've talked about a bunch of times on the show, is when that degeneration gets so bad that it starts pushing on the nerve. But really the biggest symptom with that is not back pain, it's leg pain because of the pressure on the nerve. So when someone comes in just saying that their back is hurting, that's what I mean. It's most often related to the mechanics, and the mechanics being the soft tissues, the stabilizing muscles, the things that keep the inherent structure are just probably weak. They're deconditioned for whatever reason. A lot of things can lead to that. And, it's just as prevalent in guys like me and you that are sitting probably more of the day versus people who are out there doing manual labor. Mm-hmm. Neither is perfect, right? There's a way that and it might lead to different mechanical issues, because within the mechanical aspect, there's a lot of things there. So it might lead to different structures being affected. It's a complicated type of thing.
Okay, perfect. Yeah, okay. If you have any questions for Dr. Lou, he's got answers. Give us a call, 416-870-6400. We're going to go to a break. If you want to get a hold of Dr. Lou outside of the show, it's 1-855-55-Dr. Lou. Email him at info@pinpointhealth.ca or visit pinpointhealth.ca. It's the Pinpoint Health Show on Global News Radio. We're back on the Pinpoint Health Show with Dr. Lou. I'm Danny Longo, filling in for John Scholes. If you have any questions for Dr. Lou, give us a call, 416-870-6400. Dr. Lou, I have a question for you.
Sure.
I have a family member.
Okay.
I'm not going to say who.
That's fine.
Constantly wakes up with chronic back pain.
In the morning?
Yes.
Morning?
Every morning. And they always say it's my sciatica. It's my sciatica. Okay. It's like it's been going on forever. Won't go to a doctor.
So it's mainly leg pain then?
Leg, lower back, lower back
in the morning.
She does see a physiotherapist.
So we know she's female. That's good. Okay.
Yes.
That helps me.
Yeah.
And what about age? Can we go that far?
40s, mid-40s.
40s, okay. Yeah. And how long has this been going on for?
Long time.
Yeah,
at least 10, 15 years.
Yeah, so I mean, it's interesting with morning stiffness, right? Yeah. So once upon a time, sort of when going back to mechanical back pain, one of the other, that's 95% of low back pain cases, but there's, 3, maybe 4% of spine-related low back pain cases are what we term inflammatory. So when there's inflammatory, meaning from some type of autoimmune disease that's all of a sudden starts to attack the joints in the body, the most common in the spine being ankylosing spondylitis, okay? It doesn't, it sounds big and scary, and I mean, it's not great, but it's definitely manageable. One of the big features that we use to sort of help us from a symptomatic standpoint to figure out whether we're talking to someone who might have mechanical pain or someone who might have inflammatory pain, because those are the two big ones. Mm-hmm. And again, inflammatory is much smaller likelihood than mechanical, but yet it's the two biggest chunks that we have, is we ask about morning stiffness. So inflammatory pain does tend to have this thing. Now, it's interesting, and the reason why I bring this up is because most recently there's new guidelines that have now eliminated morning stiffness as an indicator for inflammatory back pain because of how common it is also in the mechanical. So just based on that, like if we had to base this on the statistics, right, we would say now female in the 40s, though, that's sort of the age group for inflammatory stuff. She would probably have other things going on as well. Mm-hmm. How is she throughout the day?
I mean, it's a constant thing.
It's constant.
Yeah.
Okay. And
she's carrying around a lot of weight, I guess you could say.
Yeah. Is there any other types of things like gut issues or eye issues, skin issues that you can think of? Okay, so inflammatory things tend to affect more than one system in the body. So that's sort of an important thing. What about night pain? Does she wake up with pain in the middle of the night?
Yeah, early mornings a lot of the time. Because can't sleep anymore.
Right,
that kind of thing.
Yeah, I mean, and she's seen her family doctor often, or not really?
No.
And so she is doing physio.
Yes, physio, massage therapy as well.
And what is like passive in nature, where they're doing stuff to her, or active, where she's doing exercises, building her core
I think it's
up?
more passive. Yeah, they're usually doing stuff. I think she does some stretches, some things that they tell her to do.
Yeah, so the big,
she gets the laser and like that.
Right.
Kind of thing.
So those passive modalities are very good in acute settings, right? So you can have chronic back pain, low-level back pain, and then all of a sudden you exacerbate yourself for whatever reason. Those passive modalities, so passive meaning anything that a professional can do to you and you don't really, you just sort of have to lay there and not do very much, are very, very good for bringing down that initial insult. But when you get down to the chronic stuff, the long been going on for more than 6 months, and it sounds like this is the case, really the key here is building up the soft tissues again, mainly the core musculature if it's low back pain. So core doesn't just mean your abs. It means your abs, the back muscles, your glute muscles, and it's a combination of things. And there's some very key exercises that you need to be doing. But the hardest part about chronic low back pain is that the person suffering from it is the one that needs to do the majority of the work because they need to do this stuff all the time. This is not something, it's the physio, the chiros, the massage therapist job to show you what you should be doing, but it's your job to do it all the time, every single day. It's a management aspect. I always, on the show, will make this analogous to if you got diagnosed with diabetes and they told you had to go on some type of medication like a metformin, that doesn't mean you would take metformin only when you're at your doctor's office in between visits. You would take it every single day at its prescribed dose. Now, the problem being is that, pills are a very easy thing to take, whereas rehab exercises that you would have to do every day take a lot more energy. They take more time, but that is the essential component. And along with the exercises is also the modification of things, because some things that she's probably doing throughout her day are probably not the best things to be doing. So that's always something to consider. So, I mean, based on, it's obviously impossible for me to give a diagnosis, but I often, when I hear those types of non-specific symptoms, I lean towards mechanical pain. Also because it's been going on for so long, and typically inflammatory pain, at some point, if it was that bad, she may have got checked out and, had some low-level blood work, and that might start to create an indication. So, but it is something to consider. Definitely in that age group of female, you'd also want to consider the possibility of inflammatory pain.
Right. And it's probably going to be an ongoing thing unless you take the preventative measures.
It's a management thing, right? Yeah. So back pain is not, so this idea we were talking before about the cure word, right? And I'm not a big fan of the word cure because there's really no such thing that we have for anything. We have some really good ways of managing a lot of things. We have some very good ways of preventing things, but we're not that great at curing anything, right? Because the idea of a cure means you can get rid of something and it doesn't come back ever. But that's not like, I mean, we could all get the flu and we might be quote unquote cured, but that does not mean that we're never going to have it again. We have to now manage ourselves. We have to wash our hands, cover our mouths, and minimize the likelihood of reoccurrence. So especially with something like low back pain that is constant, it affects so many people, it is really management. There's no, and I think that's the harder part, is because people have this idea like, oh, I have back pain, it should go away at some point forever. And it doesn't. That's the confusing aspect, right? Because it's just sort of the way it is. But at that point, it becomes a management issue.
Perfect. Okay, Any questions for Dr. Lou? We're here in Sunday morning. It's a little bit of a different time for you.
Yeah, so we, the auto show has been on for the last few weeks, and they needed my 11 o'clock slot on Saturday. We'll be back to normal times next Saturday at 11. But, I figure we try this and see if we get some calls and see what people Sunday morning want to talk about. So
if you do have a question, it's 416-870-6400. If you want to email Dr. Lou, info@pinpointhealth.ca, or if you want to call outside of the show times, it's 1-855-55-Dr. Lou. It's the Pinpoint Health Show on Global News Radio.
The following is a paid commercial program. Unless otherwise identified, the guests on the program are employees of the advertiser. Opinions expressed are those of the advertiser and do not necessarily reflect the views and policies of Global News Radio 640 Toronto.
And we're back with Dr. Lou. Any questions for Dr. Lou, give us a call, 416-870-6400. If you want to follow him on social media, it's Instagram, Facebook, just search Pinpoint Health or Dr. Lou.
Yep, good stuff on there. A lot of, I sort of, John and I always say it's the visual aspects of the show in terms of like exercises that might be beneficial, explaining different things. You can also reach out to me if you want a specific video or something that sort of shows something that you're thinking of. I'm happy to sort of do that. And always, calling 1-855-55-Dr. Lou if you want to set up a consultation. I always tell people there's the worst that, that can happen is I shouldn't say the worst that can happen. A lot of people will call in and we speak, and it's stuff that they're already managing correctly, and they sort of maybe just want reassurance on that. Sometimes things are being managed very, very poorly, and at that point, I recommend an assessment with me, right? Because it's tough for me. This isn't something that I can be providing a diagnosis over the phone. I need to actually, because of how important the physical exam and the history is.
Right.
So, I mean, and then, a lot of these things, again, are sort of self-management. A lot of these chronic issues, which I don't just deal with chronic issues, but I guess for whatever reason, there's a lot of chronic things out there and people are mismanaged. But a lot of these chronic issues, the key really does come down to the self-management, right? And that's, we ended off speaking about the low back pain with the family member that you have. But that's a lot of the case with most chronic problems. It's self-management. And again, the analogy towards diabetes, it would be a combination of, you need to change your diet patterns, you need to change your exercise patterns, you need to take your medications, and that's really self-care at that point. And if you do those things, you can manage it very, very well.
Right.
And then you use the interventions, the medical interventions, the passive therapies, right? The things that someone else is going to do to you in the acute exacerbations, because that stuff will happen along the way. Even with the example of low back pain, you could be managing your low back pain perfectly. And I always tell people, even if you're 100% perfect at everything you do, that doesn't mean you'll never experience a flare-up again. And anybody that tells you that is lying. The reality is you'll probably minimize how likely that happens. You probably minimize its severity. You'll minimize the extent that it sticks around for, because you'll just be better equipped to deal with it. But flare-ups can always happen because, again, it's just... The thing about low back pain is it's a weak point of being human. This is nothing more than that, right? Like, we can look across cultures, whether we're looking at the third world or the first world, whether we're looking at a certain ethnic group or another ethnic group. Spine pain is just as common. It's common in terms of temporally when we've measured it throughout time over the last however many hundreds of years that it's been looked at. It's still just as common. It doesn't change. And it's really because, we stand on 2 feet. And because we stand on 2 feet, we have a low back that needs to sort of be supported. And if you do the wrong things over and over again, you're going to create some strain and sprain issues. And those strain and sprain issues will become pain. Right, and you'll face that type of stuff.
How common is it for people to come in to you and they already self-diagnose? It's like, I need this to happen, or I need you to do this for me. Yeah,
that's constant, and I think that mindset, a big thing of what I talk about on the show a lot is the mindset of this type of stuff. And part of when you're looking at any issue, you want to consider the psychosocial, which means essentially the person's psychology, their social network, all of those things. And that's huge, right? That tells you a lot of things about a person in terms of the way they come in and present, because it really speaks more than anything towards prognosis, and prognosis being how likely someone is to recover well from whatever they're suffering from. And that type of attitude can often lead to a poorer prognosis, right? Where you're self-diagnosing, you're going through those things. Mainly because the first thing that I think of is if someone's self-diagnosing is, a lot of people will search things, but when you're self-diagnosing, you're thinking you're the expert and that you know what your problem is. And the reality is here, and we were speaking, you're Portuguese descent, I'm Italian, so we all know, like, the most dangerous thing is I always get it from my family members where it's like, I'll be speaking to my aunt and she'll be like, my best friend's sister had this and this is what she did. And it's like that is the worst form of healthcare, right? And even just as another example, our clinics, we do a lot of different things. And one of the things that we run is the specialized knee clinic that we've spoken about on the phone before. And sometimes we're recommending knee surgery, right? Like, I am of the mindset to always have the most conservative approach and move towards the most invasive when required. But there are times when that invasive approach of surgery or injections or things like that are warranted. And my job is to make that recommendation. And do you know how many people I speak with and say, I heard somebody that had this really bad experience? It's like, yeah, but you're going to hear that because that's what's interesting. People don't walk around and tell you, you don't hear the story about, so-and-so's grandmother or sister that had this amazing knee operation. You only hear the less than 1% of bad things that can happen. And bad things can happen, but it's the job of the healthcare professional and the person to do the right things to minimize that.
Right, yeah. You're getting the story of, this person's only 40 years old and they had a hip replacement or whatever.
It ended up in an absolute disaster or something, whatever. And listen, that's important to consider.
Yeah.
And any good surgeon will go through the risks of the potential surgery. It's also about people doing. And the other thing is, when I start diving into these things, you start to realize how much the person who had the procedure done contributed to whatever bad thing happened, because people don't do the proper care after those types of things. They don't do the proper therapies that they're recommended to do. So outcomes don't just matter just on what the surgeon's doing in the office. It also matters on what you're doing before and after.
Perfect. Yeah. If you have a question for Dr. Lou, a health question, it's 416-870-6400. Outside of the show, it's 1-855-55-Dr. Lou. Email at info@pinpointhealth.ca or visit pinpointhealth.ca. It's the Pinpoint Health Show on Global News Radio.
The following is a paid commercial program. Unless otherwise identified, the guests on the program are employees of the advertiser. Opinions expressed are those of the advertiser and do not necessarily reflect the views and policies of Global News Radio 640 Toronto.
And welcome back to the Pinpoint Health Show. I'm Danny Longo, in for John Scholes with Dr. Lou. As usual, if you have a question, call us 416-870-6400. Outside of the show times, it's 1-855-55-Dr. Lou.
We're probably there's probably a different listenership there than is used to. I wonder if my regulars realize, like, there's a lot of people that listen regularly that reach out to me, and I wonder if they might, maybe they think the show's canceled, but as of next Saturday, we'll be back on at 11. So, but definitely anybody listening at this point, if you've got a question, anything healthcare, pain and injury related, I'm happy to do my best to try to, at the very least, as I always do, point you in the right direction. And I think that's, that's the big reason why I do this show, is really to get people in the right direction, because there's a lot of misguided information out there, and it's a pretty dangerous thing when it comes to your pain and injury issues.
Perfect. Yeah, we have a caller, I think. Just don't know.
Oh, may not
yet.
be ready. Yeah. That's okay. In the meantime, I guess one of the other things that to speak about is, I mentioned in the previous, is the caller ready?
Yeah. We'll
okay, let's take the call.
William, are you there in Burlington? How you doing? What's your question?
Not too bad. Mr. Longo, it's good to talk to you. I used to work with you occasionally back over in the Hammer.
Oh, okay.
But, my question is for Dr. Lou. So, Dr. Lou,
yes,
the boss at home is suffering from fluid in the lung space due to some other complications and so on and so forth.
Yeah,
she's had the fluid drained through a thoracentesis, and she's had like 1.5, 1.2 liters drained off on occasion. That is a lot of weight on one side of the body, and I make fun of her and looking like she try and keep things light. She's been to the bar too much and she's tilting.
Right. Okay.
So she's leaning, like, whether consciously or unconsciously, to one side, and that, as you can imagine, if you're carrying it all on the one side, is causing all kinds of biomechanical issues and so on and so forth. And so I'm wondering, are there any other than just simply trying to just lean the other way, are there other areas, other exercises that can be done to try and sort of mitigate some of these things?
Well,
you can't deal with the bigger issue, but just try to first aid it as it were.
Yeah, so I mean, I think the thing here is it's always about identifying the root cause of the problem, right? And if there's fluid being built up in the lungs, I would say that is step one. If getting that under control will really obviously, and I think you know that already. In terms of, are there other things that you could do? It's a tough one, right? Because could you try other things and lean the other way? Yeah, but I think if the thing about the body is if when it wants to do something, it will do it because it's trying to offload pressure and things in different ways. An example of that is people who have disc herniations in their low back will often have what's called an antalgic posture. So they'll sort of look like they're listing, they're leaning one way, and they're not doing that on purpose. They're doing that because their body's making them do it. Another example is with spinal stenosis. People will have this stooped forward posture. And in fact, I see a lot of people that come in, and because stenosis happens to older people and most often men, you'll have the wives there saying, I've been telling him to stand up straight. And it's like, well, he can't. Right? Like, even if he wanted to, he probably couldn't. And so I wonder if the pathophysiology for what your wife is going through is similar, right? Because the bigger thing for me, though, and everything that I'm hearing, is you'd want to really figure out the lung issue, right? Because that seems more concerning, that fluid is building up. Now, when you say fluid, do you mean like pneumonia? Like she has consistent pneumonia going on?
Well, no. What it is that she is undergoing treatment for cancer, and the fluid in the lung is a byproduct.
Yeah, byproduct.
That's why I was sort of
right.
Yeah,
Okay.
that's why I was sort of like, yeah, we know what that is. We're
Right.
dealing with that as best we can.
Yeah.
It's just more like, okay, so now, like, generally, because the problem is that she's leaning over, and you're right. It's a lot. It relieves the pressure because if she leans the other way, it impacts on the breathing that way. But it was just more like, are there some things like, because as you can imagine, right? Like you walk somebody who's got some kind of gait issue, and every other muscle in their body is weakened or overworking to compensate for that. So
right.
That's
Yeah,
what
but
I was wondering is that there's...
No, I think, again, your body will naturally do those types of things because certain systems are more important, right? Like to the brain, breathing is going to be much more important than pain in your low back. So that's her body's naturally doing that. And now that you've said that, like a whole division of pain is what we call cancer-related pain, right? And then the consequences of that. And that's definitely not my specialty. It's its own branch of medicine, oncology-related pain, because of how complicated it is with different things that go on, like you were describing with your wife. So I think, yeah, it's a sad. I don't think I can offer anything in terms of some specific exercise or thing that she could do. Unfortunately, I think the big thing is controlling the root cause of the issue. Which is obviously tougher and more complicated. But, best of luck to you and your wife with that.
Thank you so much.
No
and
problem.
That's one thing that I love is when you say you can't, it's not your thing. You don't.
I'm very honest about that. Yeah, I'm not gonna lie about that. That's for sure.
Perfect. Thanks so much for the call, Will. All right, we're going to head to a break. If you have any questions, like Will, call us at 416-870-6400. Outside of the show, 1-855-55-Dr. Lou. You can email him at info@pinpointhealth.ca. Follow him on social media, Instagram, Facebook. Just search Pinpoint Health. It's the Pinpoint Health Show on Global News Radio. And welcome back to the Pinpoint Health Show. I'm Danny Longo here with Dr. Lou. If you have a question, give us a call, 416-870-6400, just like this caller we have on the air. I believe it's Bidya. How you doing in Mississauga? Oh, and we lost Bidya. Of course. Call us back, 416-870-6400.
No problem. I saw something I think I can see here on the phone. It said tinnitus, maybe?
Yes, yeah. I believe so.
Yeah, right. It said tinnitus. So some type of ringing in the ear type of problem, and I guess maybe as she calls back, he or she, I'm assuming, but that ringing in the ear, tinnitus can be due to a lot of different things. One thing is the degenerative aspect of the ear canal as it gets older, but it can be I've spoken to people that have constant tinnitus, and it's like it can be pretty bad for someone if you had this constant ringing in the ear.
I can imagine, yeah, especially in my line of work.
Oh, geez, yeah. Yeah, that'd be crazy. But yeah, so it can be, there's a lot of different causes. I mean, I'd have to sort of speak to her a little bit more on what types of things, other symptoms that go along with the inner ear problems, like balance issues and things like that. So it's a complicated problem and can be quite debilitating in terms of the psychology of a person to have to keep going through some. I've spoken to people. In fact, my aunt has always said she's got this ringing in the ear that she's had for the last, 15 years or something. And I'm just, wow, like that's crazy. But even that, the ringing in the ear stuff, is that her calling back?
Could be. Yeah, I believe so.
Yeah,
just give her a minute.
Sure. So yeah, I mean, it'll be interesting to sort of go through. And this is the thing, right? When you just hear a symptom, it's like my head's like exploding with like a million things that it could be. Yeah. And that's why I need to ask some questions in order to diagnose, to sort of get to an idea of like, how do I start to narrow it down? And it's funny, like I remember as I was going through school, professors would always say, listen to the patient because they're telling you the diagnosis. Mm-hmm. That the way someone describes their symptoms in its temporal nature and all those things is so important. Okay, yeah, we're going to go to the call. It's Bidya in Mississauga. Bidya, how you doing?
Hello?
Yeah, how you doing?
I'm good.
So what's your question for the doctor? What's the issue?
Talking about me, it's tinnitus that I have, and he was discussing and my line got disconnected.
Yeah, so just go ahead if you want to tell him about the problem, and he can try and help you out.
Sure.
Hello?
Hi, sorry.
Yeah, that's okay. So what's going on?
So a couple of years ago, I had shingles, and 2-3 years before that, my ears, they were already ringing.
2-3 years before the shingles.
Before the shingles.
Okay.
But now, then I had shingles in my right ear, and after that, I have like the pulsating tinnitus on my right ear.
Yeah.
And I was told that probably I'm going deaf and stuff like that. So then I went and got the audiologist, done all those tests, and they said there's nothing I can do. But sometimes I feel like my head is underwater.
Yeah. Prior to the shingles, was there a reason why you had the tinnitus? Like that was diagnosed?
I have no idea. Like I didn't, the ringing was there. So eventually, I just got used to it, I guess. But I didn't really, I don't think I realized when it actually started. But I was just to hear like this, the high frequency sort of sound, but it continued.
Yeah, I wonder if it was related. So the problem here is the shingles aspect of it, right? Because so that virus lays dormant in the nerve, right? And so the nerve that goes to your ear is actually part of the brainstem nerves, and so the problem is because that virus lives in the nerve. Even when it's gone, it's not. The symptoms may be gone, but the virus is not gone. And it's sort of, I don't know if you've ever heard of the term post-herpetic neuralgia, but people who get shingles, like say across their body, even after the shingles is gone, they will describe pain in that nerve distribution and where they had that, because of the nerve being so heightened in sensitivity. Really, tinnitus related to herpes, the vervidens virus, which is what the shingles is sort of pain in the nerve as a relation to that virus. So that's a very, very difficult thing to treat in terms of post-herpetic neuralgia, because I would say you're suffering with that post-herpetic neuralgia, but instead of it being pain, the form of pain that you have is tinnitus, because that's how the nerve in the ear works. It's not a pain nerve; it's a nerve for listening. So you'd have to go into some specialty types of clinics to see that type of stuff. What type? Have you ever seen a neurologist?
No, I haven't seen a neurologist.
Yeah. Yes, I would say that something like that is sort of your next best bet, is to speak with your family doctor and get in to see a neurologist. And even maybe the first neurologist that you see may not necessarily be an expert, but they will definitely start to move you towards someone who specializes more in those types of things. But that's a tricky one as well, that type of tinnitus. But I think you need to see a neurologist.
Okay.
Okay.
It's the ringing is not so much like I've gotten used to it, but now the pulsing tinnitus in my right ear, sometimes it's like somebody's walking up the stairs.
Yeah, no, I understand. But again, it's related to the fact that shingles virus stays in the nerve, and that could be creating the problem. So there'd have to be some specialized techniques that might be able to get tried. And the only people to do that is neurologists and perhaps neurosurgeons of that sort. So you'd have to, I think that's your best bet to go that route. Okay.
Okay.
Good luck.
Thanks so much for the call. It's the PinPoint Health Show. If you have a question for Dr. Lou, it's 416-870-6400. Outside of the show, 855-55 Lou. It's the PinPoint Health Show on Global News Radio.
The following is a paid commercial program. Unless otherwise identified, the guests on the program are employees of the advertiser. Opinions expressed are those of the advertiser and do not necessarily reflect the views and policies of Global News Radio 640 Toronto.
And we're back to wrap things up here on the PinPoint Health Show. We got a caller, so let's go right to him. It's Jonathan in Kawartha. How you doing, Jonathan? Jonathan, are you there? How you doing?
Good. How's it going?
Good. You got a question for Dr. Lou?
Yes. My biggest issue is more the bigger picture. I don't feel like I have control when I go into a doctor. I try and run a blood test or screening for certain stuff, and I have to argue with the doctor on what I want checked off and what not, because quote unquote it's too expensive. If I don't use certain key words like the pain is excruciating or it's this or that, the doctor won't give me certain care. I book an appointment on a Monday. I go in and they only give me 5 minutes of time and answer one question at a time. And I ask the doctor, okay, what do I have to do to get 20 minutes of time? Oh, no, that's not possible. Okay, do I call back and do I book an appointment Monday, Tuesday, Wednesday, Thursday, Friday to address 5 different questions? Well, no, that's not how you do it either. Well, it's okay.
Okay, Jonathan, calm down there. So what's your question for me? Because number one, I cannot control what your doctor's office does in terms of bookings and the amount of time they allot for you. That is not, that's out of my control. In terms of when people, it's not really, a doctor goes to school for a very long time to know what tests need to be ordered and what tests don't need to be ordered. So it can be very frustrating when a patient comes in and thinks they know what they need in terms of a diagnostic testing, right? So that part is, and that's how you first started. I think that I don't know enough about the relationship between you and the doctor and what you're going through, but that is not the way it works. You don't go somewhere. This isn't a kiosk where you walk up to it and you're like, here, I want A, B, C, and D. These things are not. That's not the way healthcare is done. There's a reason why they're the doctor, they're the professional with the knowledge base to make the recommendations on what it is would be best for your care. Now, the other possibility exists is, people sometimes don't get along. So you might have the wrong doctor for you. And so I would encourage you to find another doctor in that sense, right? So I can't really comment again on why, the timing issues and how much time is spent with you. Do I agree that more than 5 minutes should be spent with patients? Yes, absolutely. But I don't control your doctor's office. So I have no...
Sorry to interrupt. This isn't something specific to a doctor. I have three. This goes to the bigger issue. I have 3 family doctors, and it goes to the bigger issue, which is the point I'm making.
Possible.
And it is possible. I can give you their names, their locations. So listen, the problem is anytime I go to a doctor, I can't get the allotted amount of time I want because there's no way to call in and say, hey, I'd like a 20-minute appointment. I want a 10-minute appointment. This has nothing to do with the specific relationship of my doctor or anything like that. It's that if anyone calls a doctor's office and says, hey, can I have 5 minutes to discuss it? Can I have 20? Again, I'm not trying to tell the doctor what to or not to do. But it goes to the major point I'm trying to making is that as a whole, I feel like in Canada and Ontario, medical services are out of my control. I feel like a walking doctor is a gatekeeper.
Well, then I encourage you, Jonathan, to call your local MPP. They're the ones that control, that are at Queen's Park, that control healthcare, and speak to them. That's not my job, unfortunately, so I can't really help you. But you're
missing my point again.
I totally understand your point, but you're missing my point. That is not something that I deal with, and so there's nothing that I can possibly do.
Okay, yeah. As we were out of time, I had to put him on hold.
Sure, that's fine.
Totally out of time here, but anything you just want to finish up with?
No, I mean,
point?
The only thing that I can tie in there is if you're unhappy, one of the advantages of my team at PinPoint Health is we do really try to provide the best care for patients, right? So if you're someone that has some type of similar experience where you're a little frustrated, again, I can't control what other health teams are doing out there. I can definitely control what me and my team do, and I think most people that come find that experience to be very pleasant. They get the time that's needed. They are able to be part of the health care team and not just a consumer of it. So that might be an advantage of PinPoint Health, and I'm happy to sort of try to encourage people to do that, but I'm not forcing them either. It's totally up to you and what you want out of your health.
Perfect. Yeah. And if you have a question for Dr. Lou, it's 1-855-55-Dr. Lou. Email info@pinpointhealth.ca or visit pinpointhealth.ca. Follow him on social media as well, Instagram, Facebook, all the good stuff. It's a Pinpoint Health Show with Dr. Lou on Global News Radio.
The preceding was a paid commercial program. Unless otherwise identified, the guests on the program are employees of the advertiser. Opinions expressed are those of the advertiser and do not necessarily reflect the views and policies of Global News Radio 640 Toronto.